in the last decades, surgery for benign prostatic obstruction has undergone a remarkable shift. What was once considered an inpatient procedure, now it's moving to the outpatient setting. Large datasets confirm this evolution. In this new UK study of more than 100,000 procedures between 2017 and 2022, we see an increasingly day case surgeries from 9% more or less in 2017 to 21% in 2022. Importantly, safety was not compromised, while the 30-day readmission rates were quite similar. At the European level, we see the same evolution. TURP is steadily declining, while laser and minimal invasive therapies are expanding, often with shorter hospital stay and higher day case surgery rates. In this multi-country study, analysis of over 1 million of procedures confirms that the newer technologies are driving the shift towards the same-day surgery. And what about the United States? In the last article, we showed that in the United States ambulatory setting, the practical surgeries also changed significantly. The overall number of procedures actually decreased. As you can see in the chart, the TURP remained dominant. The HOLEP showed a gradual rise, while photovaporization almost disappeared. Once we decide to perform an enucleation, we have multiple technological pathways available. We can use bipolar, or we can use different types of lasers. Let me walk you through how they differ. Each laser has its own properties depending on the wavelength, the duration of the pulse, and as you know, the power of the pulse. If the laser wavelength is similar to, or it's close to the absorption peak of the chromophore, most of the energy will affect the chromophore without causing the energy dispersion in the surrounding tissue. As you know, the holmium laser emits a peak pulse, high peak pulse, and that allows us to achieve a better disruption. It's like a more mechanical disruption of the tissue while we are doing the enucleation. On the other hand, with the TFL laser, we can achieve a better hemostasia, a better coagulation, and a precise cutting, where although during the enucleation it could be slightly more challenging. I work in a hospital that strongly promotes the day case surgery. We have started with the transureteral bladder resection, then move on to semi-rigid and flexible ureteronoscope, renal percutaneous surgery, and penile prosthesis implantation. More recently, we have extended our approach to more complex surgeries, such as radical robotic prostatectomy, and finally with the TFL laser in an outpatient setting. But I think it's important to define and understand what's the meaning in the ambulatory surgery and why it's important. We can define as an organizational and management model for multidisciplinary care that allows us to treat selected patients safely and efficiently without the need for a conventional hospital bed. It involves post-operative care handover, adherence to program quality criteria, providing providing patients with comprehensive preoperative information and with a clear protocol and a acute protocol. The main goals are straightforward, is reducing the waiting time list, improving the comfort of the patients, reduce the infection rates, minimize the readmission, and finally reduce the cost of the surgery. Up to now, the available evidence in day case enucleation has been limited to HOLEP. Several groups have reported their results, and they conclude that HOLEP day case is feasible regardless of prostate size. Even in large prostate, you can achieve good outcomes. Comparable functional outcomes to inpatient surgery, low readmission and complication rates, and the satisfaction and the safety are preserved with this technique and this approach. However, there are no published data in TFL enucleation in an outpatient setting, and for its properties, as I said before, with a better coagulation, we decided to implement it in our hospital and within our surgery day case program. So we start to develop a protocol that includes many more criteria than those present here. I have listed the most relevant ones. The patients had low comorbidity. The last surgery, it could be scheduled before the 11:30. Prostate volume up to 120 grams, calculated by MRI or abdominal ultrasound. The duration of the procedure no more than 2 hours, and finally the patient needs to live around the hospital no more than 1 hour away. About the exclusion criteria, active infection with positive urine culture, patients cannot take anticoagulant treatment, and finally the diagnosis of the adenocarcinoma. Regarding the treatment, it's important to know that we say that we have a success patient if the patient discharged within the 8 hours after the surgery. And all the patients will receive analgesics and antispasmodics. The patients must, of course, rest at home, and with health education and catheter management. And just the patients that had a prior culture positive and prior bladder catheter receive antibiotics. 24 hours after the surgery, the case surgery nursing staff call the patient and report all the complications, fever, or if the patient had hematuria. 1 day after, 2 days after the surgery, the patients come back in the outpatient clinic ward, and the nurse removes the catheter and gives to the patient and report the sexual and functional problems. So these are our initial results. In 1 year and a half, we have carried out 60 patients, and these are our intraoperative times. The total mean time was more or less 38 minutes, the enucleation time 24, coagulation time almost 6, and the morcellation time with the multicut morcellator more or less 6 minutes. As you can see, all patients has low comorbidity, and the mean prostate volume was more or less 50 grams. Of these 60 patients, 52 were discharged within the 6 or 8 hours after the surgery. No one's received a transfusion, and no one's required a reintervention. And we report the postoperative pain, and with the visual analog scale, and it was 1.3 points at the second day after the surgery. And about the complications, we had very minor complications, most of them 1 or 2 in the classification. One just one patient readmitted in the first 30 days after the surgery due to acetoacidosis and febrile prostatitis. 8 patients visited the emergency room department, 3 for hematuриas, 2 for acute urinary retention, and 3 for lower urinary tract infection. So we can conclude that prostatic enucleation in an outpatient setting is feasible and safe. Always we need to select the patients, it's not for all. This approach, the TFL or the holmium enucleation in outpatient setting, reduces hospital bed occupancy and optimizes healthcare resources without compromising space in patient safety. It's important to have a strict adherence to selection criteria, standardized surgical protocols, and structured postoperative care handover to having a good results. Providing patients with comprehensive preoperative information improves the compliance, satisfaction, and overall outcomes. And finally, our initial experience suggests that day-case enucleation might become a viable alternative to conventional hospitalization in high-volume centers. That's all. Thank you very much for your attendance.
So, congratulations. As you know, we are also trying to begin our program following you and with your help. So I think this is a very interesting new possibility. As you are saying, the key point here is to select very well the patient we are going to do it. And you are working with the TFL. Do you think it is better with TFL than with holmium because it does probably a better hemostasia, or do you think it can be, it is not a key point for the selection of the laser?
I think that both lasers are good to perform this approach. We don't use the holmium laser because we have a problem in the ambulatory area with the electrical outlet, because we can do it with the Moses laser, and I think it's important to start this approach if you can do it, because I think that if you explain to the patient that the patient can discharge in the same day, you reduce the stress of the surgery. The patients know that the surgery, it could be not so difficult, and you can improve also you can reduce the stress, and you can improve the confidence with your patient.
So thank you very much, and congratulations. We have